Welcome to the Ultimate Dental Podcast, the place where you can learn how to create a dental practice and a business life that you love. Listen in with Dr. David Moffet as he interviews successful entrepreneurs and successful business people and successful dentists as they share their business successes, their stories, and their breakthrough ideas, sharing pearls of wisdom that you can take back to your practice and implement immediately so that you can have that great practice with more patients, higher profits, and less stress. This is the podcast where great dental practices meet with successful business processes.
Hi, everybody, and welcome to today's episode of the Ultimate Dental Podcast. I'm your host, Dr. David Moffet. It is Friday morning here in Australia, and I'm talking with Jamie Marboe-Nichols, who's in Tampa, in Florida, in the United States, where it is late Thursday afternoon. Jamie, nice to see you. We've known each other, and we have met in person a couple of times back about 10 years ago. It's good to reconnect.
Yes. Played golf together about 10, 12 years
too.
ago.
That's the truth. Yeah. That's
how
right,
we
in
met.
Denver. Yeah.
That's how we
Crazy time. Jamie, welcome to the Ultimate
Yeah.
Dental Podcast. Good to connect with you.
Thank you. I'm
Now,
thrilled
Jamie,
to be here. Thank you for inviting
you are
me.
going to be talking to us about creating a bulletproof hygiene department and how to survive an audit. But before we begin talking about that, please share with our viewers and our listeners your story, because you're a dental career person. You're basically straight from school into dentistry, still in dentistry today. Tell us about how that journey came about and how you are where you are today.
Yeah. I came out of the womb. I joke and say I came out of the womb with scalers in my hand, and polishing prophy angle. But seriously, I was in California. That's where I grew up, and my my career advisor talked to me about back then this up and coming career in dental hygiene, and she said, "So you've never really know much about if you're going to like it or not. So why don't you take this dental assisting certification for the state of California?" So my senior year of high school, I took and became a certified dental assistant and decided I really liked it. And so I loaded up my little VW bus in California back then and went across to Idaho. And that's where I went and got my Bachelor of Science degree in dental hygiene and my expanded functions license and my local anesthesia license from Idaho State University.
Wow.
Woo, go Bengals. So here I am, and I was a practicing hygienist and every summer in between when I was going to college, I was a dental assistant, and then even sometimes during my college years, I would be an assistant. But I've been a dental hygienist for a long time, and have been delivering local anesthesia and in the states that allow it, placing and carving composites. And so, it's kind of been a fun journey. And now I've been an EagleSoft trainer, and I worked in the trenches for 35 years and then became a software trainer. We have EagleSoft over here. I don't know what you guys have in Australia, but now I'm a consultant and a speaker. So I've kind of done a little bit of everything except for put the drill in my hand.
Well done,
and be
and
a
I think
doctor.
that's how we met at a dental speakers conference initially, and you were just embarking on that career, and now you are a consultant, advising people, and it's great. And I've done it myself. Take the knowledge that I acquired through being a professional, being in the trenches, and now being able to help people to avoid making the mistakes that can be made, that we see being made, that we might have made ourselves, and help them, as I say, stay on the green line that gets them from where they are to where they want to be without the speed humps and the detours and the diversions that always pop up that distract us from what we're really trying to do, and that is, provide a great solution for our patients and our health for our patients, but to do it in a way that is profitable for us, so that we can lead a comfortable life and do what we want with that money, either spend it on ourselves or be giving it away to charities and support groups. It gives us that opportunity. But tell us how, now that I guess you've got, in terms of going from being a dental hygienist and then being an Eaglesoft consultant, which is dental computer software, and now you're back into building a hygiene department and coaching dental practices on how to have really great hygiene departments. So tell me how that came about, and tell me what the secret sauce is that you've developed.
Well, I worked with the same dentist for 24 years and loved him. And I had some major life changes, and I needed to do something other than just be in the trenches of being a hygienist. So I needed some benefits for me and my children. And I found out from our sales rep for the company that they were looking for one in our area. And so I applied for it, and we already were using Eaglesoft in our office for almost 10 years. So I felt like, you know what, I used it in the trenches, and I still today teach it. People hire me all the time to teach them how to use it, because I used it hands-on for 10 years. And like I said, I did it for the benefits and things like that. And I was really excited about it. It was hard though. But then I was able to learn the 100%, because when you coach it and you teach it, it's so overwhelming that when you're teaching it to the practices, which we really only teach between 5 and 10% of it.
No,
Sorry, we're getting some backlash here. And so I then realized that I had a little bit of a unique opportunity because I had used it already for 10 years. So I knew how to, in the offices, really navigate and use it to our benefit with less clicks. And so anyways, I did that. But then within a few years, I realized it wasn't my passion. So I opened up my own Marboe consulting company, and I started teaching Eaglesoft and hygiene protocol. And so that's where I am today. And then of course, when you're coaching, and I coached for an American pretty well-known company for a while, and I went back to being on my own. And speaking just kind of almost comes natural. It's how you get your clients, and that's how you get to speak to the masses on certain protocol. And like you alluded to, David, how to help them on things that, maybe through your fumbling and bumbling and mistakes that you've made, how to maybe help them avoid some of those. And so I think today's topic is near and dear to my heart, because I'm going through it right now with one of my clients. And it's been a battle, to be honest with you.
Tell us about this client and what the issue was, and how you've helped them to overcome that issue, and I guess see the blue ocean out past the problem, and get to that smooth sailing.
Yeah. Well, we're going through the review still right now. We got 2 months left, and everyone's still standing. So that's the good news. Well, so this is a single doc practice with 3 hygienists and 2 assistants. So fairly small, but still producing quite a bit and doing well. And I was referred to his practice, and I've been working with them as their hygiene consultant, and transitioned after 2 years of hygiene into basically staying with them for now 4 years. And we've been working on other protocol like scheduling and HR and different things that I don't necessarily know everything about, but at least getting them in the right direction and referring them to the right people. And so we were able to get their perio percentage from about 6% to about 49% over the course of the 4.5 years that we worked together. Now, these audits are supposedly supposed to be random. I'm not saying they are or they're not, but I can't help but wonder, as a human, with all of the AI that we have out there, if they're not looking at some sort of a pattern or algorithms that are saying, wait a minute, this code is being on an uptick rather quickly in 4 years, even though it was gradual. It wasn't like it went from 0 to 100. It was over the course of 4 years. 6% became 15%. The next year, I think we went up to 20, then we went up to 25, and then it kind of clicked. We had some changeover of hygienists, and a lot of them, it just clicked, and they looked at the mouth as disease or health, and they would make a decision. If it wasn't health, then there were certain paths that they had to take, whether it be a gingival therapy code that we use here in the U.S., where we're combating gingivitis differently than we would a bloody prophy, and or whether if they have radiographic bone loss, we would combat that with the services of periotherapy, which in our world, the codes are D43.1 and D43.2, or 43.42 and D43.41, excuse me there. So those were kind of on the uptick, and they got a notice just in the fall of this year saying that they were under a focused review for 6 months for these two codes. So that's where it all started. And I've been coaching them for 4 years. I was not concerned with things not being done right because I knew what they were doing. In their office every year. They're in Michigan. And so this insurance company for that state does not mess around. I'm finding out. I'm really finding out. So anyway, so we're getting through it, but there's definitely some things I want to that I've learned that I would love to share on this time that we're together to help people understand it. In America, not anymore. Well, this is what I was told by some of the big coding gurus that work for insurance companies and or for lawyers. So this isn't just about an insurance audit. This is about going to, having to maybe go to court because a patient is disgruntled. So all of this is not just about insurance. It's about, can this hold up in a court a lot too? So it's not a matter of in America anymore. It's not a matter of if, it's a matter of when, is what I'm told. So if you still got, a couple of decades under your belt of being a dentist, a practice owner, you're going to want to listen to this.
Really good point, Jamie. And I remember meeting an American hygienist, I'm thinking maybe 14 years ago. And I brought her down to Australia to talk to a small group of dentists down here. And she was saying that in the practices that she worked with, periodontal visits alone, as opposed to just 6 monthly cleaning visits, the periodontal visits were 2/3 of the patients were on 3 monthly visits for perio, and yet in Australia, and you'll find practices in the US where nobody comes every 3 months; they just come every 6 months. So, are they bubbles where perio doesn't exist, or are they bubbles where perio is not diagnosed? That's obviously it's just not diagnosed.
Yeah, I think it's a little bit of both. Don't you think? I think it's a little bit of both. I mean, you would have to look at the health of your country as a whole, the whole health versus our health. We know that America, a lot of Americans have we have a high incidence of diabetes and heart disease, strokes, cancers, above a lot of other countries in the world that have prevalent periodontal disease. So I don't know what the answer is to that, but I would say no matter where you're at, that is definitely underdiagnosed, even here in the U.S.
See, I look at my own mouth. Still got every tooth in my head, all 32. Only 4 of them have been restored, so 28 unrestored. But at my age and post 50, all of a sudden I'm getting food traps, and there's no cavities. It's just adult post 50 years bone loss, which is just like osteoporosis, becomes more prevalent in aging women.
Yeah,
It your gums, the skin on your
it's
face,
related.
your gums, everything ages. Everything starts to deteriorate, despite your best intentions of
Yeah.
cleaning and flossing 3 times a day. And so it's
Hmm.
if they move to it.
Yeah, but it's also hereditary. It's also hereditary. So periodontal disease is related to the interleukin 6 genotype, which is something that is passed down through the generations, possibly. I have a high level of the interleukin 6 genotype because my mother gave it to me and my father gave it to me. And a lot of autoimmunes, which periodontal disease basically is, why is the bone attacking itself in periodontal disease, or why in rheumatoid arthritis, or why is our bone deteriorating so you can go on and on and on. And if you have that, high, it doesn't mean you're going to get it. It just means that you're more at risk for getting these things. And lupus is in there, cancer, osteoporosis, rheumatoid arthritis. There's a lot of autoimmunes and they run high in my family. And so I have reduced periodontium, and at one time it was active periodontitis. I have it under control now, but I still go in every 3 months. And my mother lost her teeth and was able to have
Oh
dentures put
gosh.
in at the young age of 32. And she also was diabetic, and she died of um, uh, kidney issues related to that. My father, also diabetic, and also lost a good portion of his teeth, and also had arthritis and diabetes. So you can't tell me that that some of this isn't hereditary and in what we do or don't do. So it is definitely under diagnosed, probably, I would say, in most countries, even here in the US. But it's definitely, we are definitely going on the uprise with all of this knowledge. The problem, I fear, is that with um, more insurances wanting to do these audits, I worry that it'll go backwards. I know the insurance companies have a duty and an obligation to protect their money in what these employers that are paying and getting these insurances, you know, let's just say you work for Walmart. It is that insurance, and they pick, whatever insurance, ABC insurance for their employees. That insurance company has an obligation to make sure that the subscribers, the doctors, are utilizing their codes and being reimbursed fairly and honestly. So they have to do this. We want to say, and I'm learning so much from my dear friend. You've got to get her on this podcast, but her name is Delane Galegi, and she was Charles Blair's right hand lady. So I'll get you her information, but she's taught me a lot. Excuse me, I got to get a water because and she's been on both sides of it. She is trying to keep offices from getting in trouble with insurance companies and with lawyers and things like that. But I can understand, out of all of the world and all of the lawsuits that are going on, America has 90% of those lawsuits. So I think that's why it's easy to say now, when it comes to dental problems, possibly litigations and things, that it's not a matter of if, it's a matter of when. And the only defense our doctors and our teams have is knowledge, and to make sure they're following the rules and that their knowledge is up to date with what you can do, what you can't do, and what you need to have in order to be bulletproof from an
Yeah,
audit.
it's my observations, on my travels 10 years ago, or during that decade 10 years ago, is that insurance is a much bigger issue in the United States for dental practices and dental patients than it is down here. Down here, it's an optional thing. People pay for it out of their own pocket, and what gets me in that situation is that the health insurance companies also sponsor sporting events, and the members who pay the insurance are expecting that the money that they contribute to the insurance provides them with benefits, doesn't provide them with a banner of the company's name at a soccer event or a football event or a cricket game. And to me, that's a bit of it's a waste and a misuse of the resource, because it should be helping people to get better health. And a lot of the population need it, but ultimately, Jamie, one of the things that in my practice, it was that same issue. They say, "Oh, my insurance won't cover me for four hygiene visits a year, only 2." I say, "Well, that's your choice. If you only want to come twice a year, you're going to lose your teeth quicker than if you come 4 times a year. What do you want to do?" And you've got to take the insurance out of it as being the grand master. They believe that sometimes patients believe that if you're doing something that the insurance doesn't cover fully, then you're doing something wrong. But you're actually doing something right, because it's just a two-person interaction, them and you. When you put a third party in there, be it the government or an insurance company, that's when you get misuse on both sides. Even take household insurance, take motor vehicle insurance, take fire insurance, all that sort of thing. It's that there's misuse on both sides, and so we've got to kind of protect the sanctimony of the business relationship. Somebody mows your lawns, there's no insurance for mowing lawns. You like the guy, you pay him the money. If he doesn't do a good job, you get something else. So I always like that, back to basics.
And they are financial institutions. It's like your bank, but they are financial institutions at the end of the day. They are. And unfortunately, I used to say they don't really care about your well-being. I get that. And I think that they do want to see, I think they want to see, and I'm going to get a lot of, people saying that from America anyways, that I'm not being paid by any insurance companies for this, but I do have a different perspective since I've gone through this with this team, by talking with some of the representatives from this insurance company about what it is that they're expecting and what they're not expecting. So I felt like they really were pro team. They want to see us practicing. They don't want to see the doctor getting in trouble. They don't want to see us doing things, but they also have a higher obligation to protecting that money and making sure it's dispersed properly.
I agree. My issue was in the payment of benefits, and I put the Australian government in there as well, the benefits for veteran affairs, soldiers coming back and their widows as well. When they were paying in multiples of 5-cent pieces, you would get $28.55 back as a payment, whereas nobody in the street was carrying or cared about 5-cent pieces. That's when and one change of 5 cents across hundreds of thousands of people is hundreds of thousands of dollars, and that's where it became silly to me. In my practice, I soon learned that we had $1 coins and $2 coins and $5 notes. So all our fees were based in multiples of $5 notes, because we weren't sick and tired of running down to the bank to get $1 and $2 coins all the time to give change. It's just practicality of things, and now nobody carries cash anyways. But anyway, let's get back to the hygiene audit and how obviously this team felt, or the practice owner felt, and what were what was the, I guess, the ground zero, the day one when we get it's not an invitation to a Christmas party, it's an invitation, you're being audited. And how did that?
It's called a focused review. So an audit, sometimes we refer to it as an audit, but it really is, it's called a focused review. And the reason it's called a focused review versus an audit, from my gathering, and I don't quote me on all this, but an audit is really being audited on everything. This is a focused review because we were being audited, or he was being audited on 2 procedure codes. So when we got the letter, we were thinking, we've got this. They listed everything that we needed to provide to them whenever a 4341 or 4342 code was going to be diagnosed by the doctor. We were told that that they would be looking at that. We'd have to send 6 months worth of current documentation. So that included 6 months of a perio chart, all of their clinical notes, and all of their images for the last 6 months. And we had never been denied. We had a 99% acceptance rate from the same insurance company. And you have to understand how big of a deal this is. This is in Flint, Michigan, and it's a very blue collar area, and 70% of their patient base have this insurance. And when you're in network with this type of an insurance, a lot of the times you cannot charge the patient for what the insurance denies or doesn't cover. So that's the difference between being in network with this insurance company or out. When you can accept their insurance, but if you're not in network with them, you can still charge the patient. So this was a pretty big deal because the patients really rely on this insurance company, this insurance provider. So, but we thought we had this. We looked, I've been coaching them, like I said, for 4 years. I've been very humbled by this, to be honest, too. While I believe and still believe that I'm an excellent hygiene consultant and know, how to coach these things, I was not coaching to be bulletproof on a focused review. I'm going to be honest. And because I travel across the country and I don't live in Michigan, I was only able to see things when I was there, unless I asked for to remote into their computer and look over everything, which is what I'm doing now from Florida. But I wasn't doing that. I was doing chart audits here and there, and things looked pretty good and thought everything was fine. But all of a sudden, now that we're diagnosing and sending things off, what was once being accepted and paid for at 99% was now being denied at about 55, 57%. Wow. And I was like, wait, what's going on here? Stop the bus, push the brakes. And so we got on with them, and they've been very patient and they've been helpful. It's not easy. It's not for the weak in the knees. And when I started to look at things from my desk, my room right here, like the people at this insurance company were looking at, I realized that there was some pieces missing, that we weren't connecting the dots well enough for the person on the other side that was evaluating the documentation to say, yes, it needs to be treated this way, and we're going to put a stamp of approval on it, and we're going to pay our portion. And so I had to go back and look, and I realized when I was looking at all three pieces that the clinical side had to come up with, and they have to match perfectly. We have something here called staging and grading. I don't know if Australia is using that, but that's just a good example. If we were to put down in our notes light or early bone loss, but then which is a stage 1 in the classification of bone loss, but then we would classify them as a stage 2. Those two don't match because early bone loss is a stage 1. If we were to say in our clinical notes, moderate to heavy bleeding, but our perio sheet showed 6 sites of bleeding that were charted on the perio sheet, they could deny it, and they were. If our x-rays were not diagnosticable enough, or there was a slight overlap, or there wasn't enough radiographic imaging of the maxillary and the mandibular bone, and it doesn't matter if the pocket depth said 6 millimeters. If there's not proof on the images, it can be denied. So we finally had to get really at one point we were wanting to just go to the insurance company, and I realized that this is their playground now. We've got to play in their playground, because the ramifications of not playing and going by the rules were of a high significance to my client. And so we are really getting clear on making sure that all three of those match up. A 6 millimeter pocket doesn't mean anything when you're diagnosing periodontitis, because it can be a pseudo pocket. It could be swollen with bleeding, but not have any radiographic evidence of bone loss. And that's very important for our listeners to understand, is that you have to have all three match up. You have to have proof from the perio charting and the bleeding that match up with the images. And I teach all of my clients to look at images first and ask yourself before you ever, you're doing your morning charted audit before the patient ever gets seated in the chair. And I ask myself, do I see radiographic bone loss? Yes or no? And I even made little cheat sheets, and they would put down all the teeth. It was laminated, and they would check mark ahead of time before they ever saw the patient how many teeth they believed had radiographic bone loss on them. Then when they got the patient in their chair and they were doing their probing and they were doing their gingival index to indicate whether or not they had bleeding beyond just bleeding on probing, they would put another check mark. And so if they had both check marks there, then they could the doctor could diagnose periodontal therapy was needed, and then their notes would have to match up. The notes have been the hardest.
Yeah,
to be honest with you.
It's been a transition from the old days where it was just, this is what I did, and there's the fee, to now telling the patient and recording that and making sure that if it's, the current legislation is, if it's not.
Yeah, we used to be able to put in our we used to be able to put in our charts when we'd put down periodontal probing, we'd say see probe sheet. You can't do that anymore. You have to diagnose everything. So we use SOAP notes.
No, tell me about
those. Are you guys familiar with SOAP notes? Okay, so SOAP notes is an acronym, and I'm going to pull it up so I don't misquote it. Just really quick. Let me pull it up over here. But it is we use a lot of templates. Most softwares allow you to create a template so you don't have to do everything from scratch, which I highly recommend, but it has to be filled in and it has to be current. But when it comes to SOAP notes, if you combine the two, which Delane Galeghi has helped me with, when you combine the two, you find that, and I'm pulling them up right now, and I'm going to tell you what they all stand for, okay? So the first note, the first S, it stands for subjective. And that is things like, why is the patient coming in? What appointment type are they coming in for? A prophy, perio maintenance, a crown on number 3. So that is subjective. It's just the facts, ma'am. And it also is like patient's chief complaint, things that they're telling you about, and then the patient's symptoms. I've been sensitive to hot and cold on this upper right, or when I chew or bite on something hard down here. It may be that they don't like the color of their teeth. It might be that they have a bad taste in their mouth, whatever it might be. That's the S. And you can have a template within that S. The O is for objective. These are the unbiased observations from the doctor and or the team member that's seeing the patient. And this would be things like your medical history, your blood pressures, medication updates, things like that. Then you have the A from SOAP, and this is the assessment. This is where your professional assessment is coming. This would be an assessment from the hygienist or the assistant, and then the doctor would do the diagnosis. The doctor would then say, yes, Jamie, based on the images we've taken and based on the perio charting that David has gathered and all this information, I believe that it's time for you to do something different than a prophy. It's time for you to go into a more extensive type of debridement of the bacteria that's in your mouth. That's what is the A, the assessment. And why is the treatment required? And that is because you have bone loss, active infection, you have decay going on the backside of the tooth, you have an abscess, a radiographic abscess, whatever that is. So that's why is the treatment required? And then the P, the last one is what is the plan and what are the procedures that you're recommending? So this would be listed out by tooth number in your notes. It would also be that you discussed with the patient. You would want to put in writing that you discussed with the patient regarding the treatments and the informed consent, which would mean this is what you have. This is why doctor has recommended this treatment. If there's a referral to another specialist, like an endodontist or an oral surgeon, periodontist, you'd want to list that, the name of the doctor and why they're going. And then also if the patient declines the recommendations, patient is going to move forward with periodontal therapy but wants to hold off on bleaching, something like that. And you would put in your next visits, your next items.
That's very thorough. I like that, and simple to follow with just the 4 letters, and spells a word
Yeah.
that exists, not MAGA. But I really like that, and it's logical. You can't get to the plan without the assessment, without the objective, and without the subjective stuff. So you've got to start at 1 and move to 4.
Yeah.
It's not snakes and ladders where you can just go
Yes.
wherever you want. Really, really simple and should be easy to follow. And so you've made a template for that in every patient's notes.
I have just created a template. I've heard about soap notes have been around forever around in America, but it kind of for me fell a little bit to the way, like they were still in the templates that we were creating. There's still some sense of it, let's just say. But as you give it to your teams as a coach, they then dilute it and do what they're doing. And then next thing you know, when you're doing an audit or a focused review, you're looking at these notes and you're going, oh my gosh, how did this get lost in translation? So that's the other thing that I think is very important, is that the doctor has somebody on the team doing a random chart audit just to make it. You don't have to be in a focused review or going to a court of law to be ready for these kind of things and be more prepared by having somebody maybe do an audit a couple of times a month or once a month and just randomly pick charts from the doctor or charts that the assistant filled out. And the very last thing that's very, very important that a lot of doctors don't like to do, but this is so important, is that the doctor is actually reading the notes, no matter who filled them out, and they are signing off and verifying that those notes are accurate and correct. That's what will get you in deep trouble, the doctor. And if hygienists, they need to sign off on their notes too. It's any licensed professional in the office that is seeing that patient. And so the doctor needs to back that up. And if things don't go well in a type of focused review, the insurance company holds, they're the strong arm. They get to decide if they want to keep you as being somebody that they work with. And in some states in America, if an insurance company denies you as being one of their providers of their insurance benefits to patients, and they take you off, you're on a blacklist. And some states make you report that to their state of dentistry, board of dentistry. It can be serious.
Oh, goodness.
It's not to be taken lightly.
That's terrifying. So you said you still got 2 months to go in this audit? 4 months?
We'll get to, we're going to find out.
Okay.
We're going to find out in 2 months.
But so far, everything that you're submitting is being approved by the insurance company as being above?
Now, but halfway through it, no. Halfway through it, we were getting a little over 50%. And we're, this isn't, I reached out to about 3 or 4 of my colleagues that are consultants and asked them if they'd ever been through a focused review. And I'm going to be honest, none of them had. So I kind of felt like I was the one, and I feel like I'm the torch carrier, and I need to get this word out. I'm not trying to cry wolf or the sky's falling. That's not my point of bringing this up and bring this topic up. I'm simply trying to give everybody the power of their knowledge, and they have access to their all of their records. That doctor has access to all of them, and wait and do a little bit of backward pedaling on things not being right and sending off a couple of months of in a wrong documentation or not having it be thorough. I would rather see you practice these things now, because when you're under the gun, it is nerve wracking. It is. We've been a little bit nervous. I have to say, we've been a little hot under the collar and holding our breath. So as to whether or not they're going to say yay or nay
Of course it is,
to
because
this.
what your doctor believed he was doing correctly or believed was adequate is now being judged as being insufficient, and they need to, nobody likes to be told that in any form of situation, in a workplace, in a friendship, in a relationship. You've got to lift your game, or otherwise things are going to change for the worse. And so it's
Yeah.
it's gut wrenching to say, yeah, we have dropped the ball, or we have kind of brushed over a few things, or taken a few steps quickly, and now we've got to go back and dot our I's and cross our T's. And
Yeah. Well, it was definitely, and it was an eye opener. And I know that this team and all teams, if they have gone through these things, are better off in the long run. And this will be second nature to them, just like riding a bike. They're going to be just doing things. They just had to tweak a few things that were a big deal to the insurance company. So, and I get it. In a court of law, by having a chart audit, or I mean, chart audit, a focused review, is going to make, in case there's ever, and I doubt this team, this is a fantastic team. This is a fantastic doctor. They don't overtreat at all. They are treating patients with the disease that they have, and they're presenting them with the services and the treatment plan that fits the disease. And they're definitely doing that. There's just some loopholes and some small, you know, things that just needed to be done more efficiently, but they are treating patients with the utmost care. And I know that they are doing things right. We just had to tweak a few of these little things that didn't match up for them to, like I said, I was looking at it on my computer and over here without being in the patient's mouth, and I'm thinking, oh, I can see why maybe they would deny that, and that's when we had to take a deep dive. Just real recently, we spent 2 hours with the team going over proper documentation and coding with Delane Galeghi, and then 2 hours with me going back over the proper diagnosis and with the doctor, of course, there. But I call it an assessment for the hygienist and the doctors, making sure, because a doctor usually will agree with the hygienist, especially in my case, because these hygienists are educated at almost a higher level than a lot of offices where the hygienist just comes right out of hygiene school and doesn't have the opportunity to learn even more from a hygiene consultant. But a lot of these, these patients are being treated really, really well, and these hygienists know what they're doing. They know. It's just they didn't have all of the ducks in a row to make it go through and be figured out. So they're turning this around. I know this is going to be just fine. I know they're going to be just fine. But if you ever, I guess the last thing I can say about this is that if any of your listeners find themselves in any kind of trouble or any kind of threat, or they don't want to wait till there's a trouble or threat, they just feel like something's missing, they can definitely give me a call and get a hold of me, and I'd be happy to help them with, going in the right direction. You don't have to be in Australia or South Africa or America to follow these rules. I really think
I think they are common
these rules
sense,
pretty
Jamie.
easily.
And even one of my clients was asking about a restorative patient who was getting a bit gnarly about why treatment wasn't going as planned, and it was through the associate dentist. And I said, "Well, can you show me the diagnostic records that required this patient to have a crown on this back tooth?" And they had none. There was no photo of the tooth. There was no radiographically. It didn't look like the decay was down towards the gingival margin of the interproximal, and the bite wings were angled and overlapped. And I said, if you get called up against the board, this is just going to be horrible for you in your practice. I said, oh, maybe we should get the patient in and take the records
Yeah.
again. And I'm going, well, that's admitting that you're diagnosing without full evidence straight away. I said, you just got to keep this patient. You've got to keep this patient happy, but you've got to change your ways. Their intraoral camera was taking photos. It's just
Well, you
horrible.
have to think about what you would want. Yeah, I think you really do. We say that we treat our patients like family, and I believe the majority of them out there do. But I do think that I would not want a diagnosis of skin cancer without some sort of testing before they did it. I wouldn't want them to just all of a sudden be digging on my face without them having some biopsies done. So, a doctor shouldn't be diagnosing an abscess just based on what the patient's symptoms are, right? So the same thing goes with the hygiene records, and with this particular case, if I can't see all levels of bone, the insurance people can't either. And you are assuming because you have a 6 millimeter bleeding pocket that there's radiographic bone loss, but until you can see that abscess, until you can see that decay, until you can see that's our most non-subjective piece of material that of a document that we get is our images, and they have to be diagnostic quality, period. They have to be. So doctors, if you're coming to a chair to do an exam, whether it's hygiene but with your assistants, and you're accepting mediocre images, you need to walk away and say, please retake that,
Now, of course
because you're
they
the
are.
one that's going to lose your license.
Of course they are. Tell me, with how is AI helping? Have you seen an AI benefit in terms of diagnosing X-rays, periodontal disease?
Yeah, I think yes. And in fact, I'm going to be working. I was just talking with our good friend that was also golfing with us that day 10, 12 years ago, with, oh my gosh, I just all of a sudden lost his name. But he's with Pearl, which is one of the AIs. I'm not here selling anything, but I'm getting ready to do some videos on AI when it comes to the periodontal side. I'm going to be showing them, because there is a difference between a probe depth measuring from the attachment to the top of the tissue in what AI does, and where it measures from the CEJ to the attachment to the bone level. There could be anywhere between 1 and 3 millimeters difference in those numbers. So you just have to be careful that you understand what you're using it to measure if you're using it in the office. You also have to be, the insurance, I would say, use it as a second opinion.
Yeah. I think it's a good independent backup, as opposed to patients some patients always don't have the trust, and so they don't believe the word of the doctor, and so it's, well, let's see what the computer says, and look at the color difference.
Yes.
There's a periodontal. I guess the older people are living, and the more that people are keeping their teeth, the more periodontal disease there is, because of those two factors. If they died young, they didn't get old enough to get periodontal disease. If they lost their teeth, they didn't get periodontal disease on teeth that were in a bucket. So it's important, but educating the population who, on the outside, they don't look fit anyway. Their obesity is rising. People go to the doctor and don't end up having their blood pressure taken. They go for something else, and their blood pressure is never taken. So, to be thorough in here, I found that it was quite confrontational to patients. They go, "Oh, it's just my mouth. It should be okay. It's not connected to the rest of my body." And so there is an uphill battle for the dental profession to be taken seriously, that not only is there illness in the mouth and the blood that pumps through their infected gums is pumping through their hearts and their lungs, but also there are indicators inside the mouth that can lead to revelations about their general health as well.
Ask Exactly. No, you're exactly right. It's a whole nother topic. I'd love to, and I'm sure you've had plenty of people come and talk about the oral systemic link. It's near and dear to my heart because of my genetic connection to all of these things. And so I I don't know where we ever came up with that the mouth was a whole separate organ from the rest of the body. I don't know where that ever came up from. But it is the one place in the body that bacteria begins its journey, and it can't be fixed. It can't be destroyed by antibiotics. It has to mechanically be disrupted. And as soon as you're done mechanically disrupting it with flossing or brushing or having your teeth cleaned, whatever it is, that bacteria, that biofilm just starts all over again. It's the one organism in the body that constantly repeats itself. And it has to be disrupted mechanically.
Hallelujah.
It can't be disrupted with antibiotics. I mean, it helps,
that's the
maybe.
truth for sure. Antibiotics. Yeah, I've seen that. They have some antibiotics.
Yeah.
No, that's not going to work. We've got to get the source. Jamie, I'm respectful of your time, and I appreciate your time today.
Yeah.
Thank you so much for being a guest on the Ultimate Dental Podcast.
Been wonderful.
How do people get in touch with you? Can you tell us the quick way? And
absolutely. I have two companies. One is called Marboe, and it's spelled on the screen, Marboe, and then DC, like dog cat, but it stands for dental consulting. So marboedc@gmail.com. Or you can go to my website, which is jamiemarboe.com. I'm the only Jamie Marboe in the world that I know of. And or Implement Simply. I started an implementation program for people who are tired of going to CE events or learning something and then they don't know how to get it implemented. So I have a program. It's a 90-day program to get them off the bench of sitting there and saying, oh, I'd like to implement this or I'd like to implement that, and getting more doctors investing in their teams and getting them to these CE events again, because they can have somebody like me help them get it implemented. So marboedc@gmail.com, jamiemarboe.com,
lovely.
or implementsimply.com.
3 easy ways to get in touch with you. And as we know, as coaches, the easiest way for people to get things done is to have somebody there to hold their hand and keep them accountable and make sure it does get done, as opposed to just learning and putting it on the shelf and never reading the notes again. So, Jamie, it's been great.
Yes, I agree.
I've been working in another dental field in terms of trying to keep doctors away from lawyers, because if your practice gets audited or your practice gets removed from a list, it can be life-changing for you in your community. It can be devastating for your family. It's just not a pleasant experience at all. And so you've really got to...
No, it's not. So this goes right up that lane, doesn't it?
Not to stick your head out when they're looking for wood, because that's how you get your head cut off. So, Jamie, I look forward to finding out the final results of this audit, this review for your client. And thank you very much for sharing it with our listeners and viewers on the Ultimate Dental Podcast. Thanks so much, Jamie.
Thank you, David.
Thank you for tuning in to another inspiring episode of the Ultimate Dental Podcast. We appreciate each and every one of you for being a part of our dental community and joining us each week on this incredible journey. If you found value in today's episode and you don't want to miss out on future episodes packed with expert insights and actionable strategies, here's how you can stay connected with us. Firstly, hit that subscribe button. Whether you're listening on your favorite podcast platform or watching on our website, subscribing ensures you'll never miss an episode. Secondly, share the love. If you know a fellow dentist or colleague who could benefit from the wisdom and knowledge that we share here, please share our podcast with them. Also, please share the podcast on your socials by simply clicking on the social icons wherever you view or listen to this podcast. Together, we can all do our bit to elevate the dental profession. And finally, stay engaged with us. We love hearing from you. Your questions, comments, and feedback fuel our mission to provide the best content for your professional growth, your personal growth, and for your practice growth. Remember, your journey to creating a dental practice and a business life that you love is our mission, and we're excited to be your trusted guide along the way. Thank you for being a part of the Ultimate Dental Podcast. Until next time, Keep smiling, keep striving, and keep on tuning in to the Ultimate Dental Podcast.